So the female reproductive system is, we're going to cover it in a similar way that we covered the male. So starting off with the function of it, similar to the male, goes right along with supporting conception and pregnancy, giving birth and reproducing. We don't see the overlap with the urinary system, with the female reproductive system that we did with the male, even though they're very close together in proximity. They're not sort of sharing structure and function like we saw with the male. But we do see both external and internal reproductive organs of both. That's similar to the male, like we spoke about last week. Externally for the female, the vulva, the clitoris, and the mammary glands, which we'll be taking a look at here in just a moment. And we're on page 294 in the text, if you want to look at some images while we're going through this that we'll have up on their screen. So externally, on the female reproductive system, we're basically looking at this area here. So the vulva, which was already mentioned, sort of a catch-all term for several anatomical components of the external female reproductive system. Note that we do see the urethra being pointed out and the bladder, the urinary bladder, coming down in the urethra, which shares, if you will, that vaginal opening, but they're completely separated and independent structures. So they're not being shared with one another in that aspect. And then the breast tissue, we'll take a look at a little bit later, but obviously physically separated from the other organs of the reproductive system. Again, we'll speak about those sort of in their own area. So the clitoris also included in that vulva, along with the labia major and minor that surround the vagina. Clitoris is located anterior to the urethra. So if you've got your vagina here, and then skipping over the urethra, then we see the clitoris. Clitoris usually is mainly just an erogenous structure, so having to do with stimulation, sexual stimulation. And then internally, this is where we see the majority of the female reproductive system, including the ovaries, the fallopian tubes, uterus, the internal aspect of the vagina, and the cervix. So kind of looking at a lot here from an anatomical perspective, but if we sort of just draw around, that's our internal components of the female reproductive system, noting that here we've already discussed the urinary bladder, as well as the urethra, and then the rectum, the anus, the digestive system is posterior. So this is posterior body, this is anterior body. And you're looking at this from a lateral perspective. So it's kind of weird to think about this, but if you're just to cut someone directly in half, and then they've only got one leg left and you're kind of looking at them from the side, that would be the perspective that you're looking at here. So a lateral perspective. And then just kind of an exploded view of the interior or internal reproductive organs, the vagina, and then the cervix, which is in the beginning or the entrance point of the cervix or of the uterus itself. So kind of a clear delineation right there at the cervix line. And then several different layers of the uterus right here, the peri, endo, and myo, and we'll be looking at those in just a second. But then, of course, the uterus where the baby is going to be growing, and then the fallopian tubes and the ovaries themselves. The ovaries themselves contain these Graafian follicles, which we'll be explaining in a moment, but that is basically where the egg development is taking place and then being excreted out into the uterine tubes or the fallopian tubes. Both terms mean the same thing. And that travels down into the uterus, where, of course, if the male and the female have intercourse and it's the right time of the month where the egg is available and the sperm is injected, then that sperm and the egg are going to combine together inside the uterus and you have a human. So the ovaries themselves, almond-shaped and sized approximately, located in the pelvic cavity. That's where the egg cells are stored. The ovum is the actual cell, the egg cell itself. And then those uterine tubes or the fallopian tubes, again, you can use either term, is just the tube that sort of connects that passageway to them. One thing to note about the uterine tubes or the fallopian tubes is they actually are not connected on both ends. So if we look here, we see that they're actually not connected. They've got this fimbriae, which kind of just opens up, almost like these finger-like projections that allow, once the egg or the ovum is released, then it's just, basically it's a very, very high chance that that egg is going to be inserted and caught into the fimbriae and then traveling down through the uterine or the fallopian tubes. There is a chance that that could not take place and you could not have an egg be captured and then pass through the uterine tube. And of course, which in that case, then reproduction is not going to take place either because that egg's not available. The uterus itself, surprisingly, is about a pear shape and pear size, so not very large. However, during pregnancy, it does increase in size dramatically. And its functions are not just to carry your child, but also with menstruation and then also pregnancy and labor. So menstruation, of course, is the means to an end of pregnancy and reproducing. So you could throw them all together sort of in the same basket there, if you will. And then we spoke just briefly on the previous slide about endometrium, myometrium, and perimetrium. Notice that all of these metriums are speaking about the uterus. So here we see a word already that is giving us a clue as to what it's talking about, uterus. And then endo, we know, is meaning inside of or the inner lining, the myo being muscular, and then peri meaning around or outer. So we can see those words already coming to shape as we split them apart. And then the corpus or the body is just the term that's used to describe the central portion of the uterus or the large portion of the uterus. That, when we say uterus, we're basically saying corpus or the body of it in general. We're not speaking about a specific portion of it. Continuing on with the uterus, two different other items of note is the fundus, which is the upper portion, kind of the rounded portion of the uterus that would be anterior, so above, or cephalad, not meaning that it's sort of around the head, but it's oriented towards the upper part of the body. So if we're looking at the urethra or the vagina, for example, and then we say, okay, and then the fundus is cephalad, that'd be meaning up the body, just superior, also meaning the same thing. So fundus would be cephalad compared to the cervix. Cervix would be inferior to the fundus. So fundus, the top part, cervix, the lower portion. The vagina then, which sort of connects the cervix, the uterus to the external reproductive organs, is approximately 3-inch tube that connects those. And it is on its most distal end or inferior end would be the hymen, which is just a fold of membrane found near the opening. So near where we'd have the major and minor labia as well. There is kind of an interesting, or I don't know if it's interesting or not, it's not well known about, I guess, is the rectouterine cavity, also sort of known as a cul-de-sac. And when we're talking about this area of the body, medical terminologies, this cul is sort of going to be that clue that that's what's being talked about. And if you see here on this image, I've got circled in big red, almost looks like a thumb shaped right there in the middle, right above the uterus and on not quite to the intestine, but in between there. You can see it's closed off at the bottom or the inferior portion and open on top. So that little pouch, if you will, is called the rectouterine pouch because it sits in between the rectum and the uterus. A couple other items of note: the Bartholin glands are mucus-producing glands located on each side of the vagina. So these would be closer to the external part of the body that are secreting mucus and allow for lubrication during sexual intercourse. And then the mammary glands, including or inside of the breasts, are those milk-producing glands of the female, which allow you to breastfeed and provide nutrients for feeding babes until they are weaned. Inside or part of the breast structure is the mammary papilla, which is just a fancy medical term for the nipple. And then the areola, which is the pigmented area around the nipple. So just from a structural or anatomical perspective, that's what we're looking at. Here's a figure of that. One thing to take note of as we talk about some of the different types of surgical procedures that will take place with the breast tissue later is the pectoralis major muscle tissue that is underneath the breast tissue. So you've got this large muscle tissue here. Anytime you do any type of motion with your arm, if you're pulling arms together or you're doing a push-up or anything like that, you're using those pectoralis major muscles. Very, very important to the upper body strength. And then on top of that, you see the adipose tissue or the fatty tissue that sort of makes up the breast tissue itself. And then internally to that are the lobules, which are your mammary glands, essentially, is what they're showing there, which all then culminate and feed towards the nipple or the mammary pillow. For me, working as a respiratory therapist, not in the labor and delivery or neonatal. So what I like to do is take a bookmark, got my $1 million bill here, and I'll place it inside of that page 297. And this works for pretty much any chapter. This combining forms chart inside of your chapter. Because then as I'm going through this and I see terms that I'm like, okay, wait a minute, what does that mean again? I can just quickly flip my page back over to 297. And it's going to remind me of, okay, here's these words again, and here's what it's relating to as far as medical terms. So you may have already been doing something like that in your studies already, but if not, that's something that helps me to kind of keep on top of some of the terms that I've not used in a really, really long time. So it does take me a while to bring them back up into my recollection as well. So interestingly enough, here, first term archeo that's listed, I wasn't familiar with that use with the female reproductive system at all, nor did I find anything about it in the chapter. I looked online and I couldn't find anything about it. Now, archeo, obviously, like archaeologist or archaeology, the study of the first things, study of the beginning of things, like it makes sense, but I don't know. I guess I could see sort of how maybe that could be related to the female reproductive system, but I don't know how it's used. So it's kind of one of those words that they throw in there and they don't have any other explanation about. And working in medicine myself, I've not heard that term used for the female reproductive system, so I'm not really sure what it would be used as. But the rest of these, cervic, so most people are familiar with that, cervix, so cervico, or colp and vagin, so for vagina. Now vagino, that's pretty straightforward, but colp, we're going to see a lot later on in this chapter, and so it's kind of one of those terms that you got to keep reminding yourself, okay, that means vaginal as well. Cold, we mentioned that just previously. That basically just is short for cul-de-sac. So anytime cold is used in a medical term, it's going to be specific to that Douglas cul-de-sac or the recto-cervical pouch. Vulve and epicio is vulva. So that whole area where the vulva, those components of the vulva that we've talked about. And again, vulve, that makes it fairly straightforward. It's easy to understand that. When it starts using that epicio, then kind of have to think, okay, wait a minute, what is that referring to again? And when you come back to this page, then it quickly reminds you, okay, yeah, the vulva area. Gynec, gyneco, gyno, just referring to woman. So we're going to see that obviously with gynecology and gynecologist, physician, and the study of those items. Hymen, straightforward, dealing with the hymen, or again, that membrane at the end of the vagina. Hystero, mitri, and mitro, all having to do with the uterus. So anytime you hear the term hyst, like hysterectomy, that's dealing with the uterus. Mitro or mitri, both combining vowels, the O and the I can be used here. So this is one of the first uses of that I combining vowel that we've seen in use since learning about it right away in the first chapter. So we'll see that in play here in this chapter. Mam and mast, both referring to the breast. Men or meno for menstruation. The oophore, having to do with the ovary. So anytime you see those two O's together at the beginning of a word or within a word, that is referring to that ovary. So that's a real easy way to remember that. Perine or perineo, perineum, and salpingo or the salping, relating to the fallopian tubes or the uterine tubes themselves. Some of the prefixes, listed in this chapter. Very few here, just the peri, again, meaning surrounding or the outer version. So when we talked about that line, the outer lining of the uterus, we used peri for that. Suffixes, atresia, which basically just means like a narrowing or a blockage of a normal opening, or the lack of an opening itself. So one way that we see this from my experience in respiratory therapy is we see atresia in the narrowing of like a tracheal opening. As it narrows, it's atresing. We see vocal cord atresia as well, where the vocal cord opening into the glottis will actually start narrowing and narrowing and narrowing until it's almost completely gone. And then as far as a lack of an opening, we see choanal atresia, which is back in the recess of your nose, where at the end of your soft palate, so it goes hard palate, then soft palate as you go deeper into your mouth, you have a connection of your airways between your upper airway and your lower airway back in the retropharyngeal space. And what can happen is that you can be born and all of that is going to be just solid bone, so there is no connection. And that's what would be called choanal atresia. And so where there should be a hole or an opening, there actually is none. So that would be where atresia comes into place. Phthisis and salpinx. The salpinx, again, salpin referring directly to the uterine tube for patients. Some disease and disorder terms, now that we've got some word roots building from the word parts themselves. So this is, again, chapter 1, type 1 for our category. This is where we can actually break down some of these words into word roots. And so we see words like amenorrhea, where we've got the rhea aspect, the meno, and then the a. So we've got rhea, if you remember, that's meaning a flow. The meno having to do with menstruation, and then a as a prefix, meaning without. So an absence of menstrual flow is how we would break that word down. And you can continue to go on and do that with many of these other words. You can see the inflammation, the itis prefix that we've been using almost every week. And then what is inflamed here, the cervix. And then you're thinking, oh, colp, that's unfamiliar. What does that mean? Nobody uses that word. I don't get it. And if you then go back to your handy little bookmark and you say colp, oh yeah, there it is. It's right next to vaginal, meaning vagina. So colpitis, inflammation of the vagina. So again, some words like this that we always seem to use the other word. These can be a little bit tricky and hard to remember. Use that bookmark or that combining forms page in your book as a quick go-to to keep your mind fresh on what some of these words are. I'm not going to go through the rest of these, breaking them all down. You guys can do that through the exercises, but you can start to, really see the common word roots and then suffixes and prefixes that we've been using all along, just adding to these new word roots. Continuing on, same thing, just increasing more of these words, and these can be all found on 300 and 301 in your text. So again, just more of the meno, the metro, myo, oligo, men, so okay, we know that that's talking about the ovary, peri around metriitis. So we can break that down, the itis, the metri, and the peri. Pyosalpino or pyosalpinx. So again, referring to the salpin or the salpin, here's salpingitis, salpingocele, all relating to the fallopian tubes. So again, salpingitis then just relating to this inflammation of the fallopian tube. So the itis meaning inflammation itself, and then the salping or salpingo meaning the fallopian tubes. Here we're not using the combined form, using the combining vowel of O, because our prefix begins with a vowel. So you wouldn't go salpingoitis or try to pronounce it together and go salpingoitis, because the O and the I would be oit. And so you're not going to say salpingoitis, but it would be just salpingitis instead. Again, going back to some of those previous rules of engagement for using the combining vowels and forms. And then moving over a couple pages in your text, starting on page 305, we see the disease and disorder terms that are not built from word parts. And some of these are the more familiar items that we've all heard before, like breast cancer, cervical cancer. You know, now cervix, of course, that's a medical terminology, but that's the word we, use on a regular basis for talking about the inferior portion of the uterus. It's a common speak word, but then we add the sort of American term cancer to it, or the English terminology, English word to that. So we see that in a couple different cases. And then, of course, we add some acronyms into this, which we'll see at the very end of the slides as well. We'll include some of these acronyms. That term endometriosis, that's just back here. It's about halfway down on the second slide, endometriosis. So inside, met, cervix, and then eosis, proliferation of. And so what we see is when you've got normal cervical tissue, uterine tissue, normal uterine tissue, the met, what we find is that when it starts to be proliferated outside of the uterus, then it starts to become a problem. Normally inside the uterus, you've got your metriotic cells, but lots of different reasons can cause those cells to either flow back up through the fallopian tubes and then sort of start growing there in the fallopian tubes or on the ovaries themselves. They can sort of get caught up here on the cervix and start growing. So normal menstruation is going to move a lot of your uterine cells out of the body, right? So with menstruation, it's normal for those uterine cells to swell and to then slough off of the uterus itself and then be excreted out of the body. And when that happens, you're moving a lot of these uterine cells around. Now, again, if you've got like really heavy menstruation, it can actually retrograde flow back up through the fallopian tubes. It can also then just basically migrate themselves outside of the uterus as well, and then end up being in the abdominal cavity. And here we see it attached to part of the digestive system. We talked about it being around the cervix, implanting in the vagina, even out towards the end of the vagina. So what happens then is if that flow, it gets blocked, occluded, it doesn't get out and excreted the way it's supposed to, then you have these uterine cells that are now implanting on other areas of the body, and they start to proliferate or grow. And they shouldn't be growing in these other areas. And so then what that causes then is a lot of pain, usually, as that new metriotic cell starts to do its normal thing, inflame, swell, and then slough off, basically go through a menstruation cycle itself like it's supposed to be doing, yet it's not in an area that it's supposed to be doing in it. And so therefore it can cause a lot of pain issues. So treatment with that a lot of times is based off of hormone therapy in order to regulate periods or to eliminate them altogether. Fairly common disease that we see in the female reproductive system. Some surgical terms regarding the female reproductive system. Oh, and I should have mentioned also some of these other terms. That's where we really start getting a lot of the cancer type of terms into the female reproductive language as well. So then surgical terms, again, flipping a couple pages over, now you're on page 309 in the text. Again, not a lot new. We're seeing a lot of what we've already learned in the ectomy. So we're excising something, we're taking something out. Or we have the otomies, in which we're doing an incision to go in and open up. We see a lot of the raphes, which is that suturing. Centesis, meaning we're draining fluid. Here we see that term cold. So the coldocentesis, okay, remember col or cold, meaning cul-de-sac. So we know what space we're talking about with that. And then all of the rest of these, when we're talking about the prefix or the word root for them, cervix, colpo, episiope, and all of these hymens, hysterect. So we know that these word roots are giving us the where that these actions, these surgical procedures are actually taking place. So when we talk about hyster, again, remember that's going back towards the uterus. Even though we're not using the term uterine there, hyster is one of those words. Hymen, clearly related to the hymen that we just talked about before. And colpo, remember speaking that is related to the vagina. Just kind of keep those terms in mind as you move through some of these surgical terms. A few more as it refers to mammoplasty and mastectomy and mastopexy. Again, mam and mast, both referring to the breast tissue. And then we see some of the oophores here and salpingo. So talking about the ovaries and the fallopian tubes with salpingo fallopian tube, talking about the ovaries. Vulve here, talking about the vulva, that area that we discussed at the beginning of class. So you can really start seeing how these terms, again, it starts feeding into itself and you just keep recycling these terms over and over. One thing we see a lot of in the hospital is hysterectomies. Most often what we see is the total hysterectomy, which is TAH, or a radical hysterectomy, because those patients typically end up at least being admitted to the hospital for an overnight stay. Whereas if they're just getting their tubes tied, I'll talk about that in just in a moment, or some other type of procedure, it typically is a shorter term hospital stay, and sometimes we don't even see them. So in order for, your typical nurse, respiratory therapist, physician, you name it, that's going to be at the bedside, lab technicians, radiology technicians, in order for any of those personnel to actually see these types of patients, they're going to have to have been admitted to the hospital. Otherwise, you're going to be having to work in a gynecology practice or specifically in labor and delivery in order to see these types of terms used on a frequent basis. A lot of women have hysterectomies after a C-section, maybe with their third kid, and they're like, okay, I'm done having kids, no more. Then they'll do like a tubal ligation where they're tying the tubes. They'll do those right then and there. And so oftentimes we don't even hear about that. If it's a hysterectomy, sometimes the patient might be admitted for something else and maybe having a C-section, and then the doctor sees something while they're in there and they're like, okay, we got to look at this further. They take the baby, they go to the newborn nursery with the baby, and then they'll do an exploratory on the mom. And sometimes they find out, hey, we got to do this. Like, here's your options, talk to the husband. And sometimes then we don't hear about those as well. In other words, it's usually cancer related, and through a pap smear, your yearly exam, something will show up, then they'll do some more scopic or scopes investigation, take some more samples, and then turns out, okay, yeah, we're going to have to take the uterus to some extent. And then that's when they would come in for a procedure. And so here you can see several different types of hysterectomies listed there. Some of them dealing with just the uterus, others adding the hystero-salpingo oophorectomy. So, starting to add lots of things and bilaterally. So on both sides, taking the uterus, the fallopian tubes, and the ovaries out as well. And then a radical would be everything, including lymph nodes and the cervix and upper portion of the vagina. So this would be, in most cases, a cancer-related case where you've got cancer that is being very aggressive and it's starting to spread throughout the whole reproductive system, or has the look like it's going to. And so in that case, they're going to just take out as much tissue as possible in order to prevent that spread, in order then to prolong the life of the patient. Some other terms as it is specific to breast tissue and breast tumors. Again, here's this term radical for mastectomy. Anytime you hear that term radical when we're talking about a surgical procedure, it basically just means everything pertaining to that area. We're taking everything out. Breast tissue, nipple, lymph nodes, and underlying chest wall muscle. So remember when we looked at that picture and we had that big pectoral, the pectoralis major muscle that underneath the breast tissue lies. If we take that tissue out because we're afraid that that cancer has now started to penetrate into it, and so we need to remove that completely, that is going to leave a massively weakened area of that arm because you're no longer going to be able to pull. You've lost that muscle tissue there. And so that's going to be a major lifestyle change for that patient because of that muscle being changed. And as a result, like, it's rarely performed. Most of the time what we see with breast cancers is they do not affect the muscle tissue. We usually don't see radical mastectomies that often. A modified radical you do see on a regular basis, so breast tissue, nipple, and lymph nodes. And so that's kind of the important part there, is the lymph nodes. The lymph system is throughout the entire body, and it's a way that cancer will very quickly travel from one part of the body to another part of the body, is through the lymph system. So when you have lymphoma or cancer in the lymph system, usually prognosis is really poor unless you catch it very, very early. With breast tissue, that is one of those items that if you do not catch early, because there's so many lymph nodes in breast tissue, it's very easy for breast cancer then to metastasize or to grow and to reproduce and then spread through the lymph system through the rest of the body. And that's why regular and self exams, as well as regular yearly checkups with physicians and having the mammography done on a regular basis is so important. Because if you don't catch that breast cancer, it could metastasize and lead to cancer in all sorts of other parts of the body that will then be non-operable and give you basically 2 to 3 years to live, depending on when they find it. But if you find breast cancer early, before it travels through the lymph system, or even if it is included with some of the lymph nodes, you want to hopefully catch it early enough before it starts metastasizing. Then you can prolong a patient's life with very relative few side effects or issues. Of course, those would be related to the chemotherapy and radiation therapy itself. So a typical patient with breast cancer would be given the opportunity to choose, sort of like, okay, here's what we found. And then the physician will say, based off of what we found, here's what I recommend doing. And if it is in the lymph nodes, they're going to say, we found it in 3 lymph nodes, and that doesn't mean it's in all of the rest of them. We could go in and just tank out those lymph nodes, but chances are, and medical data shows this, that you're probably going to have more lymph node cancer following that. It's most likely that cancer is not only just specific to those lymph nodes, but is elsewhere in that breast tissue. So you're taking that risk if you only remove the lump, if you only remove the lymph nodes, and you're sort of waiting to see, okay, well, let's see if it comes back. You're sort of playing that risk game. What's the reward for it? You keep your breast tissue, certainly. What's the risk? You get that cancer again, and maybe you don't catch it as soon, even though you're having regular checkups, it metastasizes, and you die 3 years later. So there's a huge, sort of scale of the unknown there, and it's different with every single patient, of course, but over thousands and thousands and millions of patients, you start to see these trends arise. Most of the time, then the best idea, and I say the best, this is sort of my opinion here, so take it as that, is then to have all of the lymph nodes, all of the breast tissue, have all of it removed, because then you're just eliminating that high risk area for cancer to reproduce and then spread throughout the rest of the body. Do you have to do that bilaterally? Have both? You find it in one? Do we have both? No, that hasn't really been shown the case. Now, if it is in both, obviously, then a bilateral resection is necessary. But if it's just on one side, that doesn't mean it's going to grow on the other side if you remove one side. So a lot of times you'll see a unilateral mastectomy rather than bilateral if only one side is affected. And then, of course, there's all kinds of reconstruction options that can take place, everything from prosthetics, which are external, such as wearing a bra that has a prosthetic breast in it, all the way to actual breast reconstruction using your own tissue, or like silicone types of tissues as well. Some other surgical terms that we're going to look at here. These are not built from word parts, and here's where we're starting to see a lot more acronyms. So anterior and posterior, the A and P, colporaphy, again, colpo meaning vaginal, raphy meaning suturing, so suturing of the vagina. D and C, this is one we do hear quite a bit, a dilation and curettage, going in and dilating the cervix and the uterus, and then doing like a scraping of the uterine wall in order to clean the uterus out. So you might see this in like a endometriosis type of case, or in cases of miscarriage, you'll a lot of times have a curettage to clean that uterus out of the miscarriage. Tubal ligation right here. Think of the tubal ligation as sort of the vasectomy that the male had, but for the female. So and the vasectomy for the male, if this was your testicle and this was your vas deferens, you would just cut the two and then tie loops on the end so that the semen and the sperm cannot communicate. Same thing happens here with the ovary. The ovary is going to produce the egg. It's going to pop it out here. It's going to get pulled up into your fallopian tubes and then travel back through the fallopian tubes into your uterus. But if we block this, and there's multiple ways that this can be done, but the most common way is this tubal ligation, in which case they ligate or they tie off the two ends here that they've made from the cut, and they'll actually remove a portion of that so that there's no way that they can just sort of butt together and then sort of grow back together. They cut them off so they're physically separated and then tie them together. And so you probably heard the terms, you got your tubes tied, or maybe your mom got their tubes tied, or someone that got their tubes tied. This is what they're referring to in that. Literally, it's the same procedure for men getting their tubes tied as well. It's just different part of the different reproductive system. Some diagnostic terms. So now we're looking more into looking at diagnosing some of these issues that we've looked at with either the breast cancer or some of the disease or disorder terms. But again, here we're kind of looking at the same type of thing. Remember, with all diagnostic terms in the past, a lot of grams and graphies. So a lot of these diagnostic tests. Centesis, again, is another one of those where we're draining. And then lots of scopes and scopies. Either some type of gram or graphy procedure, a lot of times using X-ray or sonography. And then with a gram, a lot of times that would be like an IV dye solution that you're placing into the body. And then the scope, of course, that's using some type of video or visual scope in order to do those procedures. So we kind of know what those mean already. And then it's just a matter of, okay, remembering what are our word roots. So hystero, thinking back to the uterus, salpino, thinking back to the fallopian tubes, mammo for breast, hyster, again for hystero for the uterus, cold, remember the coldo from the cul-de-sac word, the Douglas cul-de-sac, or that recto-uterine pouch. Culpo, and vagina is your key word there, culpo or vagina. Another cold and some more hysteros. So again, these terms that, there's lots of words in this chapter, but they're all repeated and recycled for the most part. And that's why really, if you can learn in each chapter, like what's on page 297 of this chapter, those combining forms that's initially presented at the beginning of each chapter, like that's the one chart that you should just devote to your memory of every single chapter, because then you're going to just be using that through and through the rest of the chapter. It'll make the rest of these items a lot simpler. Mammography, here's an example of that. And you should be always doing sort of the self-exam, the self-breast tissue exam. If you're unfamiliar with that or you're not quite sure about how to do that, ask your primary care provider to show you, actually, put on a glove and walk you through the self-manipulation to feel what you should be feeling for. There's also, these days and age, you can find great YouTube videos for that type of stuff to walk you through it. And the American Breast Cancer Society has a ton of information online as well. So if you need sort of like steps or the how-tos, a lot of times in like gynecologist offices or just female physician offices that are specifying with female patients, not that they're females, physicians, but they'll have like little hang tags or things that are in their office restrooms that basically just have here's the 5 steps to doing a self-exam, self-breast exam. Some diagnostic terms that are not built from word parts. So we've seen a transvaginal sonography. Here's basically an ultrasound that is being done through the vagina. So we have several of these types of sonographies in medicine. One is a transesophageal sonogram, or we call it a transesophageal echo. because what we're doing in that case is we're taking the into the esophagus or across the esophagus, then into look at the heart and how it's pumping blood. So that's why it's a transesophageal echocardiogram. But in this case, a transvaginal sonography, you're using sonography, go up through the vagina, and then you're using sonography to go look through the vaginal wall up at the uterus. That's explaining sort of the word structure of that type of term. Other laboratory values, CA 125, whenever you see CA, remember that just is referring to cancer. So cancer 125 being a very specific radioactive tag referring to cancer. When we're doing a diagnostic exam for cancer, we're going to be placing these markers into the body, and they're markers that are specific to cancerous cells. And so this marker floats through the stream, and then when it finds a cancerous cell, it's going to adhere to it. And so then when we take a look at the X-ray, if you will, or the CT scan, whatever you happen to be looking at, those radioactive markers are going to just light up and glow, because that's where you're seeing, okay, there's probably cancerous tissue there because of the radioactive marker attached to it. In that case, you can go in and biopsy that tissue and see if it actually is cancerous tissue. And then the pap smear, your yearly female checkup, or as needed, if there's some other reason why it might be suspected. But here, basically just using fluid from inside of the reproductive system in order to then look at it microbiologically to see if there's any cancerous cells in that smear. So you probably all have seen sort of like those little microscope slides that you put the cell tissue on it, and then you slide it under your microscope and you look at it. That's essentially a smear. You're taking, you could take a Q-tip and swab your cheek and then smear that onto a plate. That's a smear as well. The pap smear is just directly related to the specimen from the cervix portion of the uterus. Q-tip showing the smear taken from that cervix portion of the uterus, and then this would be looked under the microscopic slide. Complementary terms built from word parts. We talked about these earlier. So gyneco, the gynecologist, the gynecology, gynopathic, the study of the woman. Leukorrhea, we know rhea is flow, and we know leuc is white. So is this some white discharge or white flow? And then mast, again, breast tissue here, vaginal, vulvo, all of these are common terms. Menar or meno, remember menopause or menstruation, I should say. So menarche would be the beginning of the menstruation. So this is typically referred to as when the females are going through puberty and have their first discharge of blood flow or their first period. Some non-word part complementary terms, contraception, of course, talking about intrauterine devices, pills, condoms, things like that are all included in that. Fistula, I think we mentioned that previously, probably in the respiratory system. Fistula is sort of like an unnatural connection or opening between two different parts. So if you have a tracheoesophageal opening or fistula, you have some type of communication between your trachea, which is anterior, and your esophagus, which is posterior to your trachea. And now you have air and foodstuffs that are able to communicate between your trachea and your esophagus. Obviously, that's not a good thing, because you should not have food stuff or stomach acid or anything like that getting into your trachea. Other places you can see this specifically in the female reproductive system would be like a vaginal urinary or vaginal bladder, so vaginal cyst or vaginal vesicle fistula. So between the vagina and the urinary bladder, you can get a fistula formed. Hormone replacement therapy, when typically you're seeing this in regards to menopause, or if you've got your ovaries removed for medical reasons, for cancerous reasons in most cases, then you're not going to be producing as much estrogen and progesterone as you normally would. And so then taking a hormone replacement therapy then is going to help you sort of recapture that normal balance that you're losing by having the ovaries removed. And some abbreviations commonly used. We've talked about a few of these already. We talked about the A&P repair when it comes to like vaginal suturing. CX is common for cervix. We talked about the D and C, the GYN, so GYN, OB/GYN, obstetrics and gynecology, intrauterine device. So all of these, TAH, total abdominal hysterectomy. So we see a lot of these that are in use that we will use in the hospital scene. The more you're in a gynecologist office or labor and delivery office, the more you're going to use these types of terminology. Okay, so that concludes Chapter 8, Female Reproductive System.